Well, thanks very much, and thanks very much to David for finally getting me down to Sheffield. Anyone from Newcastle who crosses the Tyne actually deserves a medal. We rarely do that. So my title, as you can see, is Palliative Radiotherapy. I'm from Newcastle. I'm quite proud of that. I mean, I'm born in Belfast, so that's why my accent is somewhere in Dumfriesshire. And the picture there is our new cancer centre, when there was clearly that photograph was taken before we moved in, so it looks empty, but it's not. So this talk, I want to give you some definitions of what do I mean by palliation, and I'll be very interested to see if it actually matches your understanding or potential meanings, of interpretations of palliation. I'm going to set the scene of what I do from the palliative point of view. I'm going to talk about radiotherapy in relatively simple terms, if that's okay, and then talk about the trials and what we've learned from the trials, looking at how we can actually provide best palliation using radiotherapy, and what we've done in the past, what we're doing at the minute, and I want to ask your help in trying to decide what we should be doing in the future. This day is extremely well set out, and I'm very grateful to the speakers who preceded Coffee, because they've given a very good base for me to start. And obviously the rest of the day that will also include detailed discussions about the new radiation technologies. And where does that come in providing best palliation or improvement of symptoms for our patients? And finally, what can we as clinicians, doctors, therapy radiographers, nurses, researchers, what can we learn from you who may be our patients, their carers, or from other clinicians? So that'll be the last slide. I'd be very interested to hear what you might want to say about that. So definitions, I cheated and looked up an online dictionary. So as a noun, it basically, palliative is anything used to reduce pain or anxiety. That's the dictionary definition. But obviously it basically means anything that we want to use or offer to reduce any symptom or any problem that somebody might have. My version, when I'm talking to patients, if I'm treating them with what we call palliative intent, and I must say I don't tend to use that phrase, but on our consent forms I do write radiotherapy, palliative radiotherapy, and I explain what I mean by that, which means that I'm not able, neither they or I am in a position of being curative for their particular cancer. But what I want to do is reduce the size and the effects of the cancer. Therefore, I want to try and contain it, control it, and allow their quality of time to be improved. So the main achievements by giving radiotherapy to palliate, to reduce the effects of a cancer, is to improve the quality of time. And therefore, by doing that, improve the functional ability of that person, allow them to be the real Mrs. Smith or Mr. Bloggs, and potentially also increase the duration of time that they have, but always with the emphasis on quality. And obviously trials or studies or episodes that some of you may already have taken part in or may be asked to take part in the future. And to measure the outcomes or the end results in these studies or trials of different treatments, we need to start with a level playing field. And I'm going to go back to that shortly. And we need to talk about phrases including the word randomized controlled trials, which you may have heard of, and I'll go into that a little bit as well. So setting the scene, I was appointed in Newcastle September 2000. So 11 and a half years out, I've been keeping a prospective database. And for the first 8 calendar years or so, I was referred 1,500 patients with lung cancer. And I specialise in lung cancer and in esophagus, stomach, pancreas cancer. And the initials up there, NSCLC, stands for non-small cell lung cancer. And I do apologise for immediately having an acronym or a set of initials. But that's the most common type of lung cancer. About 8 or 9 out of 10 patients with lung cancer in the world will have non-small cell lung cancer. And the pie chart there on the screen shows the distribution of the stage of the cancer. I'm sure you're aware of what we mean by that. Stage 1, bottom right, at around about 5 o'clock, So that means it's relatively early cancer, it's potentially removable by a surgeon, and if we can do that, if the patient's lung function and reserve is suitable for that, we should do it. Definitely surgery is potentially better than radiotherapy as far as we know at present. With the new technologies, stereotactic radiotherapy, which you've heard us mention already, potentially delivers what we call an ablative, so something that will actually completely get rid of the cancer to a small part of the lung. And that potentially might replace surgical resection in some patients who actually are not well enough to undergo the operation. But that's something we need to look at in trials, if we at all can. You can see that the major part of that pie chart represents the fact that the blue colour and the slightly purpley colour are stage 3B and 4, and those are patients whose cancer is relatively bulky within their chest, and so we're not able to take it out, and we're not able to necessarily guarantee curing. And stage 4 means it's actually spread beyond their lungs, gone to other parts of their body, so it's secondary spread or metastatic disease, as we doctors insist on saying. So that's obviously the majority of the patient group that are referred to me. And that therefore translates into the fact that 83% of my practice for the first 8 years of being a consultant was with palliative intent, and 17% is with radical or curative intent. Those proportions have slightly changed even in the last 3 or 4 years, and we are actually seeking out patients who are well enough for us to treat relatively aggressively with a combination of chemotherapy plus radiotherapy with curative intent, but that's quite aggressive treatment. And I think one of the things that I've had re-emphasised to myself and made a note to myself from this morning's conversations, particularly from Malcolm Babb, is that as clinicians we're never really very good at explaining exactly what the side effects are and exactly what impact they might have on you during the treatment. But obviously if the end result potentially is cure, we need to talk about whether you want to take that forward. But as you're aware, I'm talking about palliative non-curative treatment. And obviously over 9 out of 10 patients with lung cancer have a cough. So if we can reduce the cough, allow them to have a restful night without coughing, that's great. Half of the people with lung cancer potentially actually are coughing up some blood, and we also clearly want to reduce that because that's quite scary. About 1 in 10 patients actually present with discomfort or soreness or pain due to cancer having spread to their bones. And again, 1 in 10 are found to have cancer that spread to the brain. And for those who have either the slightly rose pink stage of disease, stage 3A and 3B, where I might have tried to treat them with curative intent, where they didn't have brain spread initially, 1 in 4 of those eventually actually go on to have spread to the brain. So the brain is an area that we need to work on and trying to palliate or improve the quality of time of patients with that extent of disease. So you've heard a lot about targeted therapy in the news and in clinical research, but radiotherapy was first discovered in 1895, so this is the first targeted therapy. So it's been around quite a while. We've got much better at improving how we deliver it, the quality of the delivery, the accuracy of delivery, and reducing the side effects to the organs that are around your cancer as best we can. So what do I mean by radiotherapy? I mean, again, I've fallen into the old habit of a doctor of just radiotherapy. I must assume everybody knows what that means. But basically, it means we're using X-rays, i.e. a form of radiation, to treat your cancer. And an example is that obviously when you're having a straightforward chest X-ray, as the person on this screen has had, to get that picture, we actually use relatively low dose X-rays. So we use 150,000 volts. That's the energy of X-rays that we're producing in that machine. And if you remember on your plug, it's 240 volts, or whatever. So that's low dose X-rays that gives us the pictures. If we're going to treat somebody's cancer, kill off the cancer cells, and deliver each dose of radiotherapy at a certain time period to allow the normal cells within our lungs or our esophagus to repair between each delivery of radiotherapy, we need to use much more energetic X-rays. So we're actually using between 4 and 20 million volts of X-rays. So that's what therapeutic radiation is. We're treating it to treat a cancer, to kill the cancer off, but aiming to be very clever with that, aiming accurately and avoiding the important parts of you that we don't want to cause problems to. The picture on the right of the screen is one of the newer technologies that we may be hearing about later on today. There are other types of machines. So this is a variant which Newcastle are looking at. We're also looking at Electa, which are the trade names of the machines. And this gentleman, as you can see, is lying comfortably on his back, and that's what the word supine means, just lying on your back. Arms by his side. He's got a funny little white box on his chest, just at the bottom of his rib cage. And that white box allows this clever machine to actually see how much he's breathing. And if he's got a lung cancer, where that lung cancer is moving every time he breathes. Because patients breathe. That's a bit annoying. So if I want to try and treat a lung cancer, if that's the lung cancer, I'm being very crude with this. If I take a deep breath in, if it's in the bottom part of my lung, that lung cancer is probably going to do that. And then down, and up and down. And sometimes it goes like that. Take a really deep breath. So it will move. And it potentially will move between 5 to 10 to 15 millimeters, which doesn't sound very much, but in fact, we're actually trying to keep our margins of the radiotherapy beams really quite tight. So if that's where I'm treating, for example, there, and the cancer is here, and then it's moved up there, that gets a bit silly. So we need to be using imaging to make sure, are we actually treating, sending the beams of X-rays where the cancer is? So that's what we mean by image-guided radiotherapy. And I suspect you hear a bit more about that today. Malcolm mentioned James Lind. Thank you very much. And I've discovered this society as well. There's also there's also a website, James Lind Library. This is the first sensible approach to research. And as you can see, he was a naval surgeon in the 18th century. And as you're aware, if you're headed off to sea for many, many months across the oceans and not really knowing where the hell you're going, sailors developed scurvy. And obviously the Admiralty and the government were very keen to try and figure out, well, can we prevent our sailors from actually dying? Because that's what they were doing. And nobody left to actually look after the ships. So James Lind actually took 12 sailors on a ship across an ocean. He made them sleep and live in the same part of the ship. They had the same stage of the scurvy. Therefore, they were all on a level playing field. So we've got no bias. And they were given 6 different types of treatment. And sulfuric acid was what the doctors in the government at that time felt should be used to treat. Vinegar was the Admiralty's favourite. Cider, those two probably had quite a nice time. Seawater, didn't fancy that. Nutmeg, and the other one was obviously orange and lemon. And what do you think which did best? So this was a very lovely trial, very small numbers. You'll hear statisticians and clinicians talking about we need more numbers, but clearly the 10 out of the 12 sailors got treatment that clearly did absolutely nothing for them and probably did harm. If you can imagine the sore lips of scurvy, taking vinegar or whatever. So the vitamin C in the orange and lemons clearly did the job, and those 2 sailors got much better and were able to do their jobs. And after that, the Admiralty made it mandatory that all ships had lemon juice on board and that the sailors had to drink it. So that's what we mean by controlled trials. So, and obviously the other thing we need to do is randomize our patients. So if we have a set of patients and they're being allocated to one sort of treatment compared to a standard treatment, so you've got a new treatment and a standard treatment. If we've got all 25-year-old young men in the one getting the new treatment and we've got 85-year-old women in the other arm, there's going to be clear differences that have nothing to do with what treatment they got. So we need to be absolutely clear that we have no bias in the trial. So randomization, make sure we've got similar age groups, similar genders, similar other stratification profiles, as we call it, in each arm of the trial. Now, the Medical Research Council in the UK have put a huge amount of work into palliative trials, trying to improve the status of our patients and the symptoms that we're making sure we're treating the symptoms as best we can. And in the UK, there's always been an emphasis on can we achieve the same relief for our patients with fewer trips to hospital. And that was often based on the fact that we didn't really have enough machines, linear accelerators, to deliver the radiotherapy. Plus the fact that people, I work in Newcastle, people from Berwick need to spend an hour and a half driving down to Newcastle. It's a bit of a trek. So can I give that person from Berwick the same benefit by actually just giving him 1 or 2 treatments rather than having to traipse up and down for 10 or 13 treatments? And those were the sensible questions that the UK Medical Research Council were asking. And they particularly applied this to lung cancer. And there it is again, non-small cell lung cancer. And as I've mentioned, the main symptoms of patients with lung cancer are cough, possibly coughing up some blood, feeling short of breath. And we need to balance that with the side effects of radiotherapy. And the main side effect of anybody who has radiotherapy to the lung, and some of you may have experienced this, obviously if I've got a cancer here in this bit of my lung, I need to treat that bit. But the other thing that goes down this bit is my gullet. It goes right down the middle of my chest. So when the radiotherapy beam passes through my skin, because I'm a Celt, I will get rather pink, dry skin, and then it'll settle. And I may end up with a little rectangle of tanned skin. But the same will happen with my gullet. I'll get rather dry, pink, sore, slightly raw gullet. So when I eat and drink, it feels sore. When it goes down, it feels raw. And that's what I emphasize to my patients. It may not happen as much when I give a lower dose and hopefully get the same benefit. But it is likelier to happen if I'm giving more treatments to that particular patient. And these are the type of side effects we need to be very clear about. And we also need to learn how to best reduce them, but treat them when they're there. So this slide is going to give you the headlines of each of the 3 Medical Research Council lung trials. And as you can see, the first one was published in 1991, and it actually looked at patients with non-small cell lung cancer in whom we could not take the cancer away, we couldn't operate on them because of the stage of the disease. But if they had a cough, or were coughing up blood, or had shortness of breath, we wanted to see if we can actually improve that symptom just as well by giving just 2 treatments, so 2 trips to the hospital, as opposed to giving 10 treatments, okay, which was the standard at that time. And they found that they actually got the same level, the same benefit, reduction of the cough, by giving 2 treatments. So that's easy. Therefore, we should use 2 treatments as our standard at that particular time. So they then said, okay, if we can actually achieve that with 2 treatments, it's still 2 treatments. What about actually trying to achieve that with 1 treatment? So they then looked at patients who were actually more poorly, so even just 10-minute drive, coming up for that drive, it's actually, if they're quite weary, quite poorly, they wanted to look at particularly at that group. If we give them 2 treatments, which is the standard treatment, or 1 treatment, do they get the same benefit with reduction of their cough, for example? And they found, again, the benefit was the same in each groups. So then they said, okay, so by this time we're in 1996, they actually looked at patients whose cancer was confined within the lung, and although we couldn't remove it or cure it, we want to try and reduce their symptoms, but also give enough radiotherapy to try and see if we can actually allow them to increase their time. So they compared the 2 treatments versus a 13 treatment dose. And they actually found that the patients who got the 13 treatment dose, everybody had the same benefit from the reduction of cough, but those who had the longer treatment actually lived longer. Okay. So nowadays, if patients, if we can't cure lung cancer, but if they have disease confined to the thorax or to the chest, and they're quite well, quite robust, then we would consider giving them a longer course of radiotherapy to also provide what we call a survival benefit, i.e. increase the time that they have. Obviously that's 1996, and in the last 16 years since then, things have moved on in lung cancer, and we're much more frequently offering our patients chemotherapy or systemic treatment as we know it, in addition to radiotherapy or instead of. but we also need to remember that we need to look at how these two modalities can work together for the benefit of the patient. So that's another whole tranche of area that we need to look at. Looking at further research has been again done in the UK, looking at relief of discomfort in the bones due to spread of the cancer to the bones. Peter Hoskin is a professor down at Mount Vernon in London, West London, North London, with apologies to our Londoners. He's done a very sensible trial which is looking at radiotherapy as a single exposure of radiotherapy for pain, for example, in an arm or a leg or in a spine or ribs. And comparing that to another treatment that we know potentially is useful, which is actually a drug that actually alters the strength of your bones. It's a bisphosphonate, so it actually allows the bones to improve the handling of the calcium. So it's what we call a single phase 2 trial, and that means we're actually looking at the effectiveness and how good a treatment might be. It's double-blind controlled, randomized controlled trial, so it means that if I'm the clinician putting you into that trial, well, actually no, I'm going to start that again. Actually, I'm ignore that. The evidence from the bisphosphonates has shown that they are effective in helping pain. Therefore, Peter Hoskin said, okay, let's compare a single shot of radiotherapy to a single dose of ibandronate. Sorry, guys. And that was a phase 3. So that's looking at a standard versus a newer treatment. So it's 8 gray, which is the size of the dose of radiotherapy that we give, versus a single dose of the ibandronate. And if after 4 weeks the improvement in pain does not exist or has not reached a set optimal level, then the person is allowed to cross over to the other treatment. So if they've received radiotherapy up front and their discomfort is, they would still rate that as 7 out of 10, it hasn't gone down to 5 out of 10 or 3 out of 10, they would then be allowed to have the ibandronate. Okay. So that's a sensible trial looking at a sensible question and trying to see, okay, how can we best treat bone pain? And that completed accrual or completion of the numbers of patients we need for that trial 2 and a bit years ago. We're still awaiting the full results of that. Okay. So that's one of the issues. It takes a while for once a trial is completed for the statistics to be gathered, for the reports to be written and for the information to be fed back to us, but also to our patients. So that's another issue we might want to talk about. The other important area to look at it is when a cancer is affecting the bones in our back and therefore causing reduction in the integrity of the back and pressure on our spine, and therefore reduction in potentially in ability to move and also pain. And this is one of those acronyms that Malcolm has already mentioned. So SCORA, and I have no idea what that stands for. But I suspect it's spinal cord radiotherapy at dose or not. So we're looking at spinal cord compression, whereas there's pressure on your spinal cord due to cancer in the bones. And we're giving either one single shot of radiotherapy or we're asking you to come for 5 daily trips of radiotherapy. And they initially did a feasibility study to see if it's actually feasible to approach patients who are clearly in quite a frightening situation and asking them over a 24-hour period if they're happy to be involved in a trial, and then getting on with the treatment, because obviously we need to act relatively promptly in this situation. And that feasibility study showed that it is feasible. Patients appear comfortable to be placed in that position, be asked that question, and comfortable to consider being involved in the trial. So that trial is now open. And certainly it's open up in Newcastle, and we need to pull our socks up and get more people into that. I don't know if it's open in Sheffield. I don't know if anybody else yet nods. So it's a vitally important trial. That would be very helpful for our patients. Looking back at response rates, so by that we mean whatever treatment you've given, how many patients actually notice that there's a reduction in their symptom, for example. And on the left of the screen, you've got the initial chart from the Medical Research Council lung trials. And this was the first time that they actually recorded well patient-reported impressions of how they are. So these are actually from the diary cards of patients in that trial. And as you can see, probably the most obvious thing to look at, just get me there, yeah, is the bottom here is dysphagia is our stupid word that we use for meaning soreness and swallowing. So it means difficulty swallowing or pain on swallowing. And basically, as you can see in the bottom right hand one, the ones with little dots which are difficult to see, that was just giving 2 treatments of radiotherapy, and the soreness of swallowing around about 2 weeks was at its height and then gradually settled. With a longer treatment, so 13 treatments, it actually got a wee bit more sore and it lasted for longer before it gradually settled. Okay. And that's information directly from the patients themselves. It's not me judging if their swallowing is any better or if it's sore, because how can I judge what the patient feels? So that was one of the first trials which is vital to emphasise, that we actually need to use patient-reported symptoms. So these response rates that you can see there, we probably stand around about between a half to 2/3 chance of reducing your cough, perhaps slightly more than that. We certainly stand a decent chance of actually reducing your coughing up blood with radiotherapy. We stand a very good chance, perhaps 3/4 of the way there, to improving any discomfort or pain in the bones. So these are all established facts and we can actually tell our patients. As regards symptoms from the brain, it may be that steroids on their own are what reduce the problems related to what's going on in one's brain. And we still need to explore how we should use radiotherapy to its best from the brain point of view. So that's emphasising that these are patients reporting. So from the brain point of view, the MRC, again, we're at the forefront of looking at palliative trials. And the Professor Ahmadzai might recognise this diagram because he was certainly very much involved in the initial conversations regarding how we should actually look at giving the best quality of time to our patients with brain spread from their cancer, particularly, again, non-small cell lung cancer. And as you can see, it was becoming less clear whether radiotherapy to the brain is the best way forward for patients with lung cancer that has spread to the brain. However, if a patient or clinician felt certain that they'd benefit from whole brain radiotherapy, we felt, okay, let's have a trial for that group. And therefore that trial was what's called TACTIC. So they had steroids, whole brain radiotherapy in the standard arm, and the experimental arm had steroids, whole brain radiotherapy, plus erlotinib or Tarceva, which is one of our new targeted drugs. In the middle tranche, the red arm, if, as a clinician, I'm not sure if a patient in front of me would potentially benefit or have time to benefit from radiotherapy to their brain spread, I'd need to actually try and answer that question if the patient's comfortable to go into that trial. And that trial is QUARTZ, and that's all patients are on steroids, and they're allocated either carrying on with steroids and being telephoned once a week and seen every 4 weeks. Or have steroids and whole brain radiotherapy. Okay, so it's actually trying to answer the very basic question is does radiotherapy provide similar benefit from the point of view of quality of life from brain metastases? And the arm on the right, if we're clear that the patient is actually too poorly to travel for radiotherapy, what's the best way of trying to maintain best quality of time? Steroids are certainly going to be in there, but what other template do we need to know what's the best quality of time we can deliver from the palliative care point of view or supportive care point of view? So TACTIC, its primary endpoint was actually looking at neurological freedom from progression at 2 months, and that's a mouthful. But basically they were actually measuring what symptoms somebody had at the beginning from the brain point of view, and at 2 months seeing if that had improved or had not changed at all after whole brain radiotherapy. They're also looking at side effects, quality of life, site of progression. KPS stands for Karnofsky Performance Status, which is a grading system that we have to measure how robust a patient is. And also looking at the dose of steroids. To be eligible for that particular trial, you have to be quite robust. You have to be up and about, looking after yourself, active. Okay. And that trial was based at UCL in London, and it was aiming at a sample size relatively small of 144 patients. And they're planning an analysis after 80 patients had been recruited. And the 80th patient was recruited June 2010, so just over 2 years ago. And they're analysing that, and we're awaiting those results to come out. The word on the street is that there doesn't appear to be any difference in either arm, i.e. the addition of the tablet does not seem to enhance the effect of radiotherapy, if there is an effective radiotherapy. That's probably because in that trial, all the patients, it was 3 or 4 years ago now, but they were all, none of them, we hadn't actually tested their cancer for what we call the genetic mutations, so we're actually doing much more targeting at the molecular and the cell level. So in the North of England Cancer Network, the percentage of lung cancer patients who are positive for the mutation, that means they're going to respond to the Tarceva tablet, is about 7%. So 7 out of 100 of my lung cancer patients would respond to that tablet. If I was based in Korea or Hong Kong, then I would potentially expect up to 35% of my patients to respond to that tablet. Okay, so that might explain that. The problem with non-small cell lung cancer when it's spread to the brain is that the concern is that the outlook for the patient potentially is not very good in terms of length of survival. And with apologies for putting this survival graph up, but on the bottom line it shows you that the time that patients may actually live in this situation, even though they may have been treated with radiotherapy to the brain. And the median survival, which means half of the patients would actually live for 2.7 months. Half would live longer, half would live less than that. Okay. That's not a very long time, so we need to make absolutely sure what's the best way of providing best quality of time during that. How can we measure that quality of time? And can we therefore define the optimal supportive care that we should be providing to these patients? And certainly Sheffield are taking part in the trial that has arisen from that, which is the Quartz trial. And the Quartz trial, I think, was the first trial on the National Cancer Research Network portfolio that had a consumer representative on the trial management group, who was a physics teacher from Barnsley, who's in the room. And I think we were the first trial management group to have that. And I have to say, David's contribution to the trial is immeasurable. It's kept us focused on speaking in English for a start, whatever accent. So the Quartz trial, I'm obviously the chief investigator. It's still open. This is what we call a phase 3 randomized non-inferiority trial. So with apologies, I appreciate that some of us can't see the bottom of the screen. But basically what we're looking at, we have a standard treatment that over the years, as clinicians, we felt we should be considering giving radiotherapy to patients with lung cancer that's spread to the brain. But we're becoming less certain that that actually is providing the best treatment in terms of quality of time and possibly length of time. Therefore, we need to compare that to a treatment which is primarily steroids on their own. And the question in non-inferiority means that the experimental arm, which is steroids on their own, we're assuming that that's no worse than the standard arm by a specified margin. And that potential marginal compromise in effectiveness of steroids without radiotherapy is actually worthwhile due to lack of side effects and enhancement of quality of time. That's the premise of a non-inferiority trial, if that makes sense. So patients who go into that trial, they're on steroids already. They get allocated to either carrying on with the steroids and having whole brain radiotherapy, which takes 5 trips to the hospital, or carrying on with steroids on their own, and they're phoned every week by either the research radiographer or their lung cancer nurse specialist, as happens up in Newcastle, and get asked questions addressing what symptoms they might have, what are their needs at that particular time, how they're feeling, what their quality of time is. And if they're able to come up to clinic every 4 weeks, myself or whichever doctor's looking after them will see them there as well. So we need 534 patients to show that there's less than a week difference between the quality adjusted life years, or QALYs, with steroids on their own or steroids plus radiotherapy. The other important things we're looking at is obviously overall survival. And the other unique feature about quartz is that we're looking at the effects of the dilemma that the patient is in, the effect of the disease, the effect of any treatment is having on their carer, okay? Both from the carer's mood, quality of life as well. So measuring quality adjusted time. These three diagrams are just a very simple representation of the data that we collect. So we have patient A. Now the scale at the bottom is in weeks, but let's say it could be months, it could be years, it could be decades. So they've lived for 10 weeks, they've had the best quality, so that quality is excellent throughout their life. The next patient lives the same length of time, but actually documents their quality at that time as clearly quite less. So they probably have a 50% on a very easy mathematic thing, difference in quality of life. The normal patient obviously is having treatment at different times, therefore their quality of time may depend on what treatment they're having and what side effects they might be having, or the effects of the cancer that they're having. So by actually ringing them up every week, we're able to actually get the information regularly and have a clear idea of what's happening to our patients and what treatment impact that has. So where does the new technology come in? We've mentioned stereotactic radiotherapy already. It might allow us to deliver the deliver the dose to the cancer whilst avoiding important things such as the gullet, other parts of the lung, delivering it specifically to very small areas within the brain. It's very important that we continue to look at trials, including radiotherapy plus the newer drug treatments. How do they work together? But it's vastly important that we keep our eye on the quality of the patient's time. So quality, 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 not just of the delivery of the treatment, but of the time for the patient. So what can I learn from you, or what can we as clinicians learn from you? 3 days ago is the World Clinical Trial Day on the National Cancer Research website. NCRN has been in existence for about 12 years, and 18% of all cancer patients in the UK go into trials. That's quite impressive. The numbers that actually go into radiotherapy trial is tiny. So those trials are primarily drug related, which is exciting and sexy. Radiotherapy trials are not deemed quite as exciting. We need to enhance the profile of radiotherapy, we need to continue working on it. So what symptoms do you think we should be looking at? What outcomes and benefits should we be actually emphasising? Should we be looking at patients and carers? What do you think of acronyms? Okay. Thank you very much.